Hi, everyone. Welcome. Today we are talking with Dr. Cody Morris, who has the podcast called Behavior Analysis in Practice. And we are excited to learn more about him and a specific topic that I think is really relevant to a lot of us in the field. So, welcome, Cody.
Thank you. Thank you for having me. I'm excited to chat with you both today.
Yeah. To start, if you can give our audience a little bit of background about you and what you do in the field.
Sure. So I did all my training undergraduate through PhD at Western Michigan University and kind of got the bug for behavior analysis there. Went there just interested in doing psychology, and then they really kind of wrote me into the whole behavior analysis thing. Started working with my mentor Stephanie Peterson there, who got me into being interested in working with individuals with developmental disabilities and challenging behavior. And much of my clinical work since then has focused on assessing and treating challenging behavior, but has somewhat morphed into looking at sort of complications and issues that practitioners face when trying to implement behavior analysis out there in a, confusing and messy world. And so looking at strategies to help either streamline assessment and treatment strategies, looking at things from like an OBM or an organizational perspective, and then looking at things that affect our field on a large scale, such as things like licensure or sort of conceptual issues. And so my research in some ways is kind of all over the place in that way. I like being able to dip and dive wherever I like to, but yeah, that's sort of me in a nutshell.
It's also great, though, with your research that you're not just looking at, okay, this one student with autism, they're doing this, so let's try this, but you're actually looking at it from a larger picture. So it's not just about the one tree in the forest, but what does the forest look like as a whole? And what kinds of constraints do we have? And what are we working with? And how do we work within those constraints?
Yeah, I think ideally being able to do both is important, right? Being able to narrow in and get really specific. And like, I was just speaking with someone the other day about how a lot of research is like really honed in to developing these like really specific nuances to assessments and treatments. And that's great and very important, but can be complicated if you don't have things like procedural fidelity, right? So, like, all these nuances don't really matter if you can't do the thing in the first place. And so, like, I think the doing research to identify those nuances is incredibly important, but we also need research on the procedural fidelity and all the other things that impact practice, right? And so, I kind of dabble, I guess, in many of those areas.
You mentioned, tackling some of the challenges that practitioners experience in the field. What are some of those? If you could expand on the most common challenges for us.
I think there are several challenges. I think that our field is in this really interesting growth stage. And I think there are complications related to funding, acquiring the necessary funds to provide the services that we want. The pressures related to obtaining that the funds that are available, right? So like insurance companies have a specific perspective on what should be done. Schools that are funding services have a perspective on what should be done, right? So then we're getting kind of boxed in to certain structures, which may or may not be the most useful, in any given situation. I think we have this proliferation of the number of BCBAs entering the field, which is amazing, but I'm not sure that the training and support structures have developed at the same rate. And so I'm not sure that your average BCBA entering the field has the level of training and support necessary to be as successful as I'm sure they want to be. Right. And so, I think I could go on and on. I guess I'll
But
stop
you have
there and
5 hours?
yeah.
A lot of growing.
I spend a lot of time thinking about this stuff, maybe more than I should, but yeah.
It's so true though, as soon as, you write the exam and you get that pass, grade, and, you think, okay, great. I can do this, and give me a caseload of 50 kids, and I can, and then the overwhelm sets in, right? Is, how come I can't do this? How come I can't balance 50 kids? Or, oh, I can only balance 10. How come the person who's seasoned, can do assessments in 20 minutes and I have to do them? It takes me 3 hours to do the same report or whatever it is. And there's a lot of challenges that way for sure. And just Sharon and I have always said this in terms of those newly minted BCBAs, that we think that there should be some type of learning period afterwards. So, now, the one requirement for supervision that's coming in is that in order to supervise another up and coming BCBA, you have to have at least 3 years in the field. But you can still practice as a BCBA the minute you pass that exam.
Yeah.
And not everybody's supervision experience has been the same. So I wish you could just grab a mentor and hold their hand for a while.
Yeah, my wife and I were in school at the same time. She's a clinical psychologist, and we started our grad programs at the same time. And we wrapped up our like coursework and our research around the same time. And when I graduated my PhD and I'd already obtained my BCBA credential along the way, I was, practicing, right? Through grad school, I had supervision in grad school, but in theory, I didn't, it wasn't required. I didn't need it. Whereas my wife, was doing clinical work through grad school under supervision. She finished the PhD. She did a year pre-doc internship with more supervision. Then she had to do a year post-doc internship with continued supervision. And so the question I often pose to people is clinical psychology inherently more complicated than applied behavior analysis? I don't think so. I personally
Okay,
don't think so.
we deal with such challenging behavior, families who are really in crisis. It could be very sensitive to, do the wrong thing or suggest the
Yeah.
wrong.
So then I think, okay, if we're not inherently in a field that's easier than clinical psychology, why are our training standards so much more reduced than theirs is? So not saying that the clinical psychology training, arrangement is necessarily the best, I don't know, but it is shocking the difference with fields related like that.
Yeah, ours really could be better, and hopefully we'll get there. There are enough people, I think, in the field who recognize it and want to change it, which is great. I mean, it's a big part of why we started what we do, is just to continue to provide more of the practical support. Once you're a BCBA, it's when the learning kind of starts instead of
Yeah,
finishes. And so we try to do that to our community. And one of the things I was saying earlier that we do is we make it really practical. And one of the things that you mentioned being interested in is the topic of assent, working with the learner and having really respectful and model that assent properly. And I know it's something that's kind of new for us in the field. It's not something we talked about 10 years ago. So I'd love to hear more about it. I think starting with how you would define assent and what you call it.
sure. So I think even before getting into the definition of assent, I think it's important to always couch this conversation in that although the conversation of assent in some ways is relatively new or gaining popularity in behavior analysis, I do think as a field we have a very rich history of taking the client's perspective and trying to incorporate the client into clinical decision making as much as possible. I think, B.F. Skinner wrote about the client's perspective in 1953. Montrose Wolf has the paper on social validity looking at it from all those perspectives. So I think we have this great history, but we do have, developing strategies, procedures, methods, and we need to continually refine those things. And I think one thing that our field has started looking at recently is assent. So like this idea that a client who is not legally permitted to provide their own consent, so typically, a child or someone who has a guardian of some sort, indicating their willingness to engage in a procedure or participate in a procedure via like a choice arrangement after they've received adequate information about that procedure, right? It has to be informed. They have to know or be aware of what they're choosing, with the expectation that they could withdraw their assent at any time, right? Those are kind of like the four components of assent. And there are many things that are related to assent. There are many ways of incorporating clients into the clinical decision making, assent being like one sort of subcategory of that overall focus.
So how much is kind of understanding, for lack of a better, behavioral term, a requirement of assent, or is it more just your presence and your being there? You don't need to actually understand what I'm explaining to you if you're explaining it outside of the treatment room, versus just your presence and not withdrawing from the treatment room is considered assent. Is that clear?
Yeah, I know what you're talking about. I think it's incredibly important for the clients to be able to discriminate the choice of being able to engage in the procedure or not.
Mm-hmm.
And there does need to be a level within that discrimination of being able to distinguish between the choice to engage or the choice not to engage. And I think this particular component of assent has led to some confusion or some complications because I think a lot of people are really passionate about involving clients in treatment decisions and have maybe read about or heard about assent and are very much like motivated to involve their clients in the assent process and embed it into treatment as much as possible. But with that excitement, I think people are susceptible to overgeneralizing the idea of assent, maybe in some cases shoehorning other ways of involving clients in treatment decisions into this idea of assent. Like, hey, this is assent, which I think compromises the integrity of the concept of assent, which I think is important for several reasons. One, we didn't invent the idea of assent, right? That's existing concept in society. And there are existing expectations for what assent involves in society. So like there some of the work I've done and published on defining assent. I didn't make those parameters up. I was borrowing those and utilizing other resources. And so I think if we take other things that aren't quite assent and call it assent, one, that's somewhat frankly misleading to the public who already have an idea of assent and already have this idea that like assent needs to be informed, for example. And two, it's not actually truly getting at the purpose of getting assent, which is that you are involving your client in the treatment decision at a certain level. Now, there are other ways of involving clients in treatment decisions that maybe not quite as involved or quite as complicated that are incredibly important and useful and valid. And so I think we should honor those things and really lean into doing those things as well. But I do think we have to maintain the integrity of the concept of assent while we do it.
Thanks for saying that. Honestly, where do I start? When you think about assent, right? And it's assent and it's the new thing. First of all, you're right. It's not a new thing. We should be doing this all along. It's definitely compassionate care. We need to be involving our clients. But when people hear about, I've got to obtain consent, I work with all ages, but especially I work with adults in group homes. And, I've got some adults in group homes who are very verbal and can chat and everything else. And, we've got to get buy-in, or we're getting buy-in from one individual just to do basic hygiene skills and clean his room. And that's got to come from him. It's not about, him getting some stars on a page for doing this. He doesn't, by the way, but it's coming internally from him. Like, you need to clean your room because this is a goal that you stated that you wanted to work on. But then I also have people in a group home who are completely non-vocal. They have no life, or very limited life skills, limited communication skills. And, people are saying, well, bring them into the room and talk about their BIP and, see if they nod and agree. And you're like, are you kidding me? They don't even understand clap your hands, let alone, okay, I'm going to read you this service plan and we're going to go through this. And can you sign on the dotted line? Like, it's not going to work.
So what would Assent look like in those situations?
Well, so in that part, first, I've got a connection to you in the way that I sort of started my career off working in group homes with adults, and so I'm appreciative of the complications of that particular population. And in fact, the second scenario you described is basically what got me interested in this idea in the first place, which was I was asked to attend a treatment team meeting, or was it's like a treatment plan meeting. And it was like a few weeks or months in. I was very early into my clinical experience. And I went to a group home. It was a meeting, like the group home manager was there, the social worker was there, I was there as the behavior analyst. And the social worker spent maybe 2 minutes describing the treatment plan that was like 50 or 60 pages long. Slid it over to the client who's scribbled on the line that they pointed at. And it's like, cool, we've got consent now. And I went, I don't know that they know what they just signed, So it sort of got me thinking a lot about this and looking at it. And to answer the question about in that situation, right? So you have a client. In this particular situation, they were actually their own guardian, but let's say that they had a court-appointed guardian, which is not uncommon in that realm, who signs off. Yep, this treatment plan's good to go. You have a client who has limited skill set. Let's say that they don't have many communication skills. Is Assent applicable here, right? And so first and foremost, I think you have to consider what skills do they have? Can they discriminate and choose between activities? If so, then I do think you can do Assent, right? It's not going to be as simple as, hey, here's what we're about to do. Are you cool with that? You'd have to set it up and kind of, do we describe in some of the work we do, like a concurrent operance assessment or concurrent chains assessment to facilitate the choice. But that's a way of reaching a population who don't have robust communication skills in a way that still enables them to provide Assent. But let's say that they don't have those skills, and they don't have the skills really necessary to do even that type of Assent arrangement. Well, in that case, I would personally advocate for focusing some of the treatment on helping them develop some of those skills so that we can get to Assent down the road. And in the meantime, incorporate them into treatment decisions as much as possible in whatever way is possible, right? And so, those things are so individualized in terms of what skills people have, what interests they have, how we can incorporate them. I think in general, it's a well-established precedent in behavior analysis that we incorporate clients into treatment decisions as much as possible. The question is, on the practical side of things, how do you do that, right? It's because it's going to look different in every single scenario. It's going to look different for an adult who has communication difficulties living in a group home versus a 3-year-old kid receiving ABA services in a clinic, right?
Well, that was my next example, is that, you've got a 2-year-old or a 3-year-old who's receiving services or not. If I'm thinking about my daughter when she was 2 or 3, I would never sit her down and go, okay, this is what we're going to do. You're going through the terrible 2 stage, so you tantrum a lot. So mommy is going to, there's no way.
No, but it wouldn't be a choice either if they wanted to be toilet trained.
Exactly.
It wasn't a choice.
No, it's, you're going to do this because I said so. Not, I'm not, so Assent to me is very much about, okay, so are they still involved and are they willing to participate? So even in terms of a skill acquisition program, whether it be for an adult or a child, and it's like you said, a makes a choice program, if they're not running from the room and they're sticking with me because they really want one of those choices, to me, that's assent. They're assenting to that program.
Yeah, I would say that engagement, showing other indices of happiness, I would say all of those things are incredibly important. They're indicators of the client's approval and interest in the procedures. To me, it's a measure of social validity. But I would say it's not quite assent given the sort of existing conceptualization of assent. Like, for example, if you said, hey, that's assent to a pediatrician, they'd go, what are you talking about? That doesn't meet sort of the existing. In some cases, like in the United States, and you guys are based in Canada, the United States, the federal guidelines for research specify what assent has to look like, right? And so that's where I think we have to differentiate when we're saying this is like I'm talking about like actual like a scent versus what I call like a scent adjacent behaviors or other things that are related to a scent or potentially related to a scent that are incredibly important and useful and an indication of the client's interest and willingness to participate in the procedures, but it's not quite a scent.
So I had this situation recently, actually, similar, a 3-year-old who was doing ABA for quite a while, and then all of a sudden the environment changed because his program became a lot of fun, and he started really not wanting to leave the program to go do ABA because it was a lot more fun to, at this point it was more fun to be where he was during the day. It was like a camp program. And we were having this conversation about like, okay, what does that look like now for him? Because we don't want him to not want to come. We can make it more fun and reinforcing, but he's kind of telling us he doesn't want to be there and to do ABA, but his mother wants him to, right? So now we're at this place where, okay, what would that look like to get him to assent? Like, what does that look like for a 3-year-old who his parent does get to decide, but he doesn't want to come?
Yeah, I think that behavior analysis is in this funny like crossroads of sorts of different professions. If you look at, let's say, special education, there's no choosing whether you are going to get reading lessons or math
Right.
lessons or like that's part of the curriculum. That's a legal requirement. You have to do that, right? So, I mean, there's choice in the day in and day outs of things, of course, right? I don't mean to imply that like schools are like dictatorships, but there's certain requirements and all kids have to go through all those requirements. And then there's like, traditional psychology, which, is primarily talk therapy based and it's all through the client and it's all client initiated and right, it's very much this consent assent sort of driven treatment or therapy. And I think behavior analysis in many ways is sort of in between the two, right? Where I always tell people when people are like, what is behavior analysis? Like, it's basically a cross between special education and psychology. But then it puts us in this funky position of when we're looking at necessary treatment, right? We're talking about academic skills that were within a school context, or we're talking about skills that are necessary for their long-term success, right? And treatment. Are those optionals? Are those things that we should be waiting for the client to opt into doing, or are those things we should be going like this is just necessary treatment? We kind of have to persist with that. My argument would be when there are necessary treatments, assessments, etc., assent is not necessarily applicable, and that cuts across fields, as I was saying with special education, but like in pediatrics. Do you think that pediatricians are getting assent to draw children's blood when they need to get a hematology report? No, right? Like, no, I don't think there are very many 3-year-olds in the world that, regardless of the rationale, regardless of how you set up the context, regardless of anything, you're gonna be like, go ahead, yeah, stick me with the needle and draw my blood. I don't
You
think
get the
that's
parents'
happening.
consent.
What's that?
You get the parents' consent.
You do get the
Yeah.
parents' consent, exactly, right? And so, and I think that's an important piece of what we do, of course, is making sure that parental consent and other indications of social validity, I think, are important. But from my perspective, as much as I think assent is important, and as much as I focus on advocating for the use of assent in practice, it it's not the end all be all. There are other indications of the services you're providing, their social validity, their effectiveness, other components. We can't, I mean, we were talking earlier about, like 3-year-olds. Like 3-year-olds, you can't describe everything and go like, okay, this is why like you have to, you know, go pee pee in the potty. Like that, like they're like you just have to train them to do it. They're not going to necessarily often do it. It can be a little scary, right? You shouldn't be like overly coercive and forcing. And I think that's where, uh, like two sides of the spectrum, right?
Yeah.
But I think we have to look at other measures of social validity, look at parental involvement or, teachers or other groups who are working with things like that.
So should we be changing our definition of assent for specific cases like that?
I mean, I'm probably biased. So I published a paper in 2024 in JABA that outlines a definition of assent that I'm pretty fond of. And so I would say that should be our definition of assent. I don't know if everyone agrees with me or not, but that's what I think. And again, that definition is based on the U.S. federal research requirements. It's based on the American Academy of Pediatrics. They've been doing work on assent conceptually for years, decades, really. And so I'm pulling over that stuff. I'm going, okay, like this is what existing groups that are already been interested and concerned with assent have outlined, or like the components. And they've required a little bit of translation, of course, to be more so in line with sort of how we talk about things in behavior analysis. But I do think we need to be a little bit rigorous with the definition and maintain its integrity. I do think that that's very important. And again, I think it's important for our interactions with other professionals and just conceptualizing what we're doing, right? So the example I give is, let's say that we're doing a procedure with a client and they're smiling. That's can be great, right? That can indicate that they're really enjoying it, right? And if they're enjoying it, well, that probably means that they are happy to do it and are willing to do it. But there's a few logical assumptions we just made in that process. One, does smiling mean that they're happy? Sometimes yes, right? Sometimes no. And I think we've probably all been in situations where we smiled in a awkward or tense situation, right? Does that mean that we were consenting or assenting to whatever we were experiencing when we were kind of smiling awkwardly? And then, okay, but let's say in this particular situation, they are happy about it. Well, does happiness necessarily indicate that they're assenting? The example I'll give on this is a lot of people are happy to like play on their phone and play on whatever app, and they're excited to scroll through it. They may not be super happy that that app is like stealing their data and selling their data off, or things like that, violating their privacy. And so if you're like looking at through the camera what this person's up to, they're smiling. Oh, they're happy, even though our app is, stealing their data or whatever. They're not consenting to that, right? Just smiling doesn't mean there has to be an implication of that they understand what's happening. And when they understand what's happening, that they're still agreeing to do it.
I mean, I feel like it's also the comparison every website you go to is like, accept cookies.
Yeah.
Like, and you technically click it, but no
Yeah.
one really understands what that means. You just want to get to the website. Like,
Yeah.
a similar example of like, that's a great metaphor.
Well, I think one of the things we have to be careful with as a field, and Pat Fryman actually warned against this, I want to say in the early 90s. I don't remember the exact year, but we have to be careful of getting into this like sort of checkbox
Mm.
attitude around things like consent and assent. He was talking about it in terms of consent, but we can't go, okay, like as a field, we are sort of honing in and appreciating the importance of assent. Cool. Let's get whatever we can get. Oh, the client looked in my direction. That's assent check. You know, I've got it, and on paperwork, I can say that I have it. That's you're not really getting to the heart of the matter, right? And it's like another example I give. When I was a kid, I always wanted to play video games with my older brother. He's 7 years older than me. And I was young. I was do the annoying little brother routine, like let me play, let me play, let me play, the block the TV, all those little tactics. And to appease me when I was very young, what he would do is he'd give me a controller, right? Wasn't plugged
Wasn't
in, or
connected.
maybe it was plugged
Right.
in, but it wasn't connected
Wasn't
to
playing the
the,
game.
yeah. And so here I am, very young. I'm pushing the buttons and I think I'm doing stuff, right? But then I get a little bit older, 5, 6 years old. I'm pushing buttons and I'm like, wait, what am I even? This isn't connected to anything, right? On the surface level, it looks like he's involved me in the game. I have the controller. It seems like I'm doing things. I'm not actually doing things. It was a charade, and what we have to, I think, avoid with Assent is creating charades and going, oh, we just got Assent.
Mm.
Did we? I think we have to be very, very careful with that. Sometimes, and I'm not saying that we have to be stuck on this rigid, like this traditional view of Assent of like it's written, like they have to write their name and they have to read it and they have to understand everything. I'm not saying that either. But we can't lose some of the important components, being that they have received adequate information about it, that they can discriminate between their choices, etc.
I think it almost comes back to what we started the conversation with, which was like being in this field involves so much nuance and so much like clinical judgment and things that were not necessarily things that, like you said, can check off the task list and be trained to do. It involves this like ongoing clinical judgment and like really learning and not it's not a rote thing that coming into the field you have to be able to really hone these skills, and it's not simple. And that's really, I think, one of the challenges of our field growing and expanding as quickly as it is. What we also like to do is offer a piece of advice to, we call it the newly minted BCBA, but really any BCBA coming into the field. What is something that you would offer them as your advice?
Listen to the BAP podcast.
Listen to Behavior Analysis and Practice podcast. That maybe, but the advice I give my students is, in my experience as a program director and a professor, like my students get bombarded with offers for jobs when they get credentialed, and they get, these companies promise them this and that, etc. They give them really appealing offers, frankly, many of them not always being so accurate in terms of what it's going to look like. But what I always encourage my students to do is to prioritize getting good supervision their first 1 to 3 years of credential, right? Like take the pay cut, make the longer commute, work in the less ideal whatever if it has a better structure of supervision, because that supervision is going to be like so valuable to their long-term success in the field. Yeah, I've had students that are like, "Oh, I got asked to be the BCBA at the school district." I go, "Cool, like are there other BCBAs working there?" Nope, I'd be the only one. I really don't recommend doing that. Not right away. Go somewhere where there's some seasoned BCBAs that have the ability and the willingness and the infrastructure to support you and supervise you. Do that for a few years. And then, yeah, if you want to go, be a pathfinder and start behavior analytic services in schools, cool. But you need a few years of experience under your belt. Like, I think it's so important to the development. I think otherwise people end up getting put in situations where they're not providing the level of services they want to, which is disappointing to them. It's problematic for their clients and often leads to burnout and other longer term issues.
Sure, and I still are thankful for each other in terms of being able to bounce ideas off of. And we're
Oh,
not
yeah.
unlimited. We're not, we're seasoned professionals, and we still seek each other out in terms of advice.
Yeah, I
Yeah,
think
you
it's
know, I'm sorry I interrupted. What was
no, go
that?
ahead.
I was just gonna say, I'm not sure why this exists, but it seems like many individuals in our field struggle with the collaboration and seeking um, what's the word I'm looking for? Consultation when they're struggling. I like if you go into an emergency department and are seeking medical advice, and this happened to me not all that long ago, nothing serious, I'm all good. But nevertheless, I had like 12 different specialists coming because one would go and this isn't quite my thing. Let me bring in the other person, let me bring in the other person, let me bring in the other person because they're all about referring out and seeking consultation and matching you with the right expertise. In our field, I get that we have less infrastructure and stuff, and there's some complications with doing it, but I'll consult with clinics and be like, yeah, we've been, navigating this issue for like 4 years, and like you haven't sought consultation for 4 years, you didn't know what you were doing with this kid for 4 years. That's scary, and unfortunate, I think.
And I think we sometimes feel like we have to do everything and be everything for everyone, and you become kind of a jack of all trades as soon as you get your certification, which is also unfortunate because there's so many different expertise that we can leverage off of, and we definitely can do better. And I
Yeah.
hope we continue to.
Yeah. No, I think so. And yeah, the jack of all trades thing, I think is a problem. I mean, I think people believe that they have to be that. I always tell my students, look, like figure out what your scope of competence is, what you can hone in and get better and better at, and do that job. And if your company's pressuring you to take on clients that are outside of that competence, say like, hey, I can't do that, or if I am going to do it, I need supervision. But you need to be able to sort of understand the parameters of quality services that you can provide and be comfortable with that. I mean, I can't provide services to every single person that would benefit from behavior analytic services, right? They're like, I don't do feeding stuff, advanced feeding stuff. Like, I seek consultation with those things or refer away. So I think that's an important skill for the newly minted BCBAs.
For me, that's a really good reminder. I'm already thinking like I should have referred that one out. I'm gonna do that more.
Just the ability to say no is an art in and of
Yeah.
itself, right?
Yeah.
And I think as a field, we need to start saying no more because A, it's in our ethics code, and B, we're busy enough, and C, there are competent professionals who can do something, and it's about the client in the long run, and we need to do what's best for them.
Yeah. I think it's an important piece of maintaining integrity. And I don't mean something as dialed in as like procedural fidelity. I just mean like there are limitations on what an individual behavior analyst can do or an organization can do. And bringing in every single client that you could possibly fit into the center or, saying yes to every single I know it's coming from a very good place, right? Because we just want to try to help as many people as possible. But when we spread ourselves too thin, we're weakening our integrity, diluting our services, potentially contributing to, long-term negative impacts on the clients by not providing high quality services and certainly not doing any favors in terms of the reputation of the field.
Absolutely.
Yeah.
Sure.
We could talk about this forever because it's fascinating and really your insight is very, very helpful. So thank you for being here. I'm so glad we got to meet you, and we'll share everything about your podcast and hopefully your journal articles also in the show notes. So thank you.
Cool. It's been a really fun conversation. I appreciate you guys having me on the show today.
Thanks, Cody.